selective serotonin reuptake inhibitors. When we look at what the data on the treatment of anxiety with SSRIs, so if I say anxiety, separation anxiety, generalized anxiety, socialized anxiety, we don't have any big studies. We don't have the big studies like on Ritalin or on Risperdal or on Abilify. We have case reports. So we have, like in 1997, 9 children who had transition-induced anxiety, separation anxiety, generalized fears. They all got sertraline, which is Zoloft, and they all improved short-term. And we have several other case reports that show that maybe this Zoloft was helpful in treating some aspect of anxiety in kids on the spectrum. But what we really need to do is we really need to design a large trial with 100 kids and randomize them and give one group sertraline and one group placebo to see if this really indeed is effective. In terms of stereotypic and repetitive behavior, the largest study to date is on Celexa. Very disappointing results. No effect on stereotypic and ritualistic behavior in this particular study. There's another study on Prozac or fluoxetine, which shows that Prozac does improve ritualistic and stereotypic behavior. Luvox is another SSRI, no difference from placebo, and the rest have not been studied. So what's interesting is that SSRIs are the most commonly prescribed medicines in kids with ASD, but we have the least evidence to support their use. And here I just want to show you the data from the positive study that we found of fluoxetine, which is Prozac. We found that it benefits both adults and children in reducing repetitive behaviors. And if you look at the bottom half in the children, the mean dose was 9.9 milligrams, very small. And so it's possible, can we say, that kids are responding to smaller doses of SSRIs, and they don't need the larger dose that kids who are typically developing would take, who are of comparable age. And this is why, unfortunately, Prozac only comes in 10 milligram capsules. And so this is why using a liquid preparation would help. And when I start with Prozac in an 8-year-old child, I say, let's go with liquid and let's go with 2 milligrams. And let's stay there for a month, and then we'll go to another 2 milligrams. Because there might be these little windows in which you see response, which you wouldn't see at 10 milligrams. This is citalopram, Celexa, 12-week study, very large, 149 kids. Those who received citalopram, 33% had a reduction in repetitive behavior. But look at this, placebo, 34% had a reduction. So very disappointing. This medicine did not result in an improvement in one of these core symptoms exhibited by kids with autism. And citalopram had a lot of side effects. It caused hyperactivity, impulsivity, insomnia, decreased concentration. The mean dose was 16.5 milligrams. Whether kids would have responded at an earlier dose, at a smaller dose, I don't know. And here we have the graph from the study, and all the other graphs I've shown you, you see the improvement and the drug group and the placebo group are separated, and here they overlap. The placebo and citalopram groups are on top of each other, showing no significant improvement in ritualistic repetitive behavior. So does that mean we give up on Celexa? No. I mean, a lot of these studies are based on, they report averages and mean results. Is it possible that some kids might respond? Yes. Have we looked at Celexa for other conditions like anxiety or irritability? No. So there still is a lot of work to be done before saying, this medication may not be effective at all in this population. Side effects of SSRIs, we have physical side effects and then we have behavioral side effects. So the most common physical side effects are they cause some stomach upset in the beginning, changes in appetite, headache. Most prominent though, what we need to pay attention to are the behavioral side effects. And the top one in particular, activation. There is a syndrome called behavioral activation that occurs on SSRIs. And behavioral activation basically is a syndrome characterized by an acceleration of the central nervous system. The child becomes more agitated, more irritable, more impulsive, more hyper, they can't sleep. And it's usually dose dependent. So what I hear is, we're on 4 milligrams of Prozac, we bumped to 6, and boom, child became very behaviorally activated, very difficult to control the behavior. So it is seen in a dose-dependent fashion, and the treatment of it is to reduce the dose to the previous level in which there was no behavioral activation. In kids with a family history of bipolar disorder, there's a risk for mania. In kids who are on high dose of SSRIs, there's a syndrome of apathy and amotivation when medication actually backfires and the child doesn't feel like doing anything, they almost look depressed. And the final one is the suicidal ideation. There's a black box warning out on SSRIs, all SSRIs, and the black box basically says that there's a higher risk of suicidal ideation in individuals who take this medication. The risk is very small, about 4% on kids taking SSRIs. But nevertheless, something to watch out for. In terms of monitoring of SSRIs, there's all sorts of clinician practice guidelines about weekly monitoring, and then bi-weekly monitoring, and then monthly monitoring. Some of these are really unrealistic. I mean, I know families can't get into the clinic once a week for monitoring, so what I usually do is ask parents to do the monitoring, at least for the first 3 or 4 weeks, and then to call me if they have a problem with it, and then check in with them and have them come into the clinic within 1 month, and within 1 month after every dose increase. The 2 points to note about the SSRIs is, one, it's important to develop a crisis plan, because as I mentioned, they can cause behavioral activation, they can cause mania. And so, it's important for us to talk with families about what are we going to do when that happens, and how do we manage this. I had one family whose son became behaviorally activated on a Sunday, and the mom took him to the ER, and he was hospitalized. He came out, unfortunately, on lots more medication than he needed. Still had a lot of anxiety. We decided to pursue another SSRI trial, and this time I gave her 5 tablets of Ativan. And I said, if he is behaviorally activated, give him one of these until I call you back. Again, try to divert the emergency room, try to divert the inpatient if you can. And then the other piece is to avoid abrupt discontinuation, because there can be a withdrawal syndrome that you can get if you suddenly decrease the dose or suddenly stop it. And it's a very uncomfortable flu-like syndrome that kids can get. So as with all medications, if the intention is to come off the medication, then it needs to be done very closely and with close monitoring. The other medications for stereotypies and ritualistic behavior are the risperidone and aripiprazole. I wanted to bring that up because remember I mentioned that they have broad coverage. They not only are mood stabilizers, they treat hyperactivity, they treat compulsions, they treat repetitive behaviors. But, we need to look at the risk-benefit ratio of the SSRI or the atypical. And when you look at the antipsychotics, they require a lot more monitoring, blood work, cardiac monitoring, looking at weight, looking at other metabolic parameters. SSRIs, no blood work, no cardiac monitoring, but you got to look for psychiatric changes. Generally, though, in a child who's got a strong family history of bipolar disorder, sometimes we will lean towards the risperidone or the aripiprazole. Again, it's very individualized choice based on other factors, based on many factors. Okay, so to conclude, there are some very well done, large, established studies of psychiatric medications for co-occurring conditions in kids on the spectrum. I've reviewed the evidence for methylphenidate, which is Ritalin, which is one of those large studies. Some really nice studies on risperidone and aripiprazole. The data on fluoxetine are promising. I think we do need a larger study for that, but we do have a large study of Celexa showing that it did not reveal any significant benefit. So I think in the last decade we have seen some progress in research in studying the effects of medication, their efficacy in improving co-occurring conditions in kids on the spectrum. There is an enormous amount of money devoted to autism research, and I know that there are many clinical trials underway now, and so I think in the next decade we are likely to see much more data come out on some of the other medications that I didn't talk about today or that were studied only in smaller trials. And I think what we're going to be seeing is trials looking at combination therapies, medication plus therapy compared to medication alone or therapy alone. And I think those data will be very important, and I think hopefully will result in larger health policy changes in terms of getting all these services authorized so that we can really truly deliver multidisciplinary treatments for kids with ASD. But I think until then, we do have quite a bit to work with. We have the data I presented with you to you today. We have data that we extrapolate sometimes from adults and sometimes from typically developing kids to help guide our decision choices. And so I think until then, we need to use the tools that we have to help kids. And the most important thing is that we collaborate with families, and that this is a joint, collaborative, working relationship to assess the efficacy of medications in your child. Thank you very much. I'll stay for 5 or 10 minutes after, just informally, if anybody has any questions.